Right. I think all this time we kind of knew about the metabolic effects of treatment. I suppose that's what we knew. But we were not very knowledgeable about how metabolic ill health leads to mental illness. Okay. So it's not about treatment causing metabolic ill health that we all know, but the new area is in how it actually precedes the onset of mental illness, the metabolic health. Of what we mean by metabolic health, we'll come to that later. So let me just take a classic story. I think you all have all come across this. You start treating somebody with schizophrenia and you use olanzapine, and well, maybe sometime after a few months, they have gained 20 kilos in weight. And also, of course, later they might develop even diabetes and hypertension. And then we ask ourselves, okay, how did this happen? Did we cause it, or were there other reasons for this problem? Which came first? So I think we often blame the olanzapine and say, okay, that caused the problem. But that's not the whole story. We now know that it's a kind of a two-way street, not a one-way street. So metabolic illness affects our metabolism. Okay, we know that. Not only the medicines, the illness itself affects the metabolism. Uh, the metabolic dysfunction affects the mental health or even the mental illness. Okay. And there's a feedback between the two loops. This diagram is actually not accurate. It should be a loop. Okay. So the first bit is the new thing where we didn't understand how the metabolic dysfunction precedes the onset of mental illness. That's the most critical information you need to get from this. Now, of course, we knew that people with severe mental illness, by which we mean bipolar illness and schizophrenia, die 10 to 20 years earlier than the people who don't have serious mental illness, provided other things are equal, of course. Now, they don't die of suicide, they die of cardiovascular and metabolic causes. So the majority of that death is due to cardiovascular and metabolic reasons. For example, diabetes risk is increased 1.5 times in depression. Schizophrenia, twice the risk. Okay. Now, the new thing we know is that bipolar disorder, metabolic dysfunction increase the risk of bipolar disorder. That's the other way around. Metabolic dysfunction increased the risk of bipolar disorder by 3.5%, 3.5 times. That we didn't know. Of course, bipolar disorder causes metabolic dysfunction as well. That is also true. Okay, but what we didn't realize was that the metabolic dysfunction comes before the onset of the bipolar disorder. So people who develop bipolar disorder have a higher rate of metabolic dysfunction. We didn't know that because we didn't check people before they got the disease for metabolic dysfunction. We tested them afterwards. But now we know that that's not the whole story. Uh, of course, you might say, okay, people with serious mental illness have other issues, so that's why they have metabolic problems. For example, most of them are inactive, they may smoke, diet is poor, sleep is disrupted. The medication that we give, most of our medications, antidepressants and antipsychotics, increase weight. And of course, we know that chronic stress drives insulin resistance. So people who have a mental illness are more likely to be stressed, and that drives insulin resistance. Okay. So these are only some of the mechanisms. Again, not the whole story. So let's take it from one end. Okay, psychotropics and metabolism. We know most of this, but just to complete the story, the highest risk is with clozapine and olanzapine. There is a moderate risk with quetiapine and risperidone. I'm just putting the ones we use in day-to-day clinical practice. Low risk could be aripiprazole. That would be what you would use in Sri Lanka, I suppose. Ziprasidone is available in Sri Lanka, but privately in a few shops only. I have had about 2 patients on ziprasidone in Sri Lanka, so it's available. It's not available in Australia. It's available in United States, I think, but not in the UK. What we have is a newer version of aripiprazole called brexpiprazole, and we have another one called lurasidone. I think there's another one that I haven't used, but they are called cariprazine. And there's another one, I forget, it's there. It's available in India, and at Sri Lanka, we almost got it down, but then in the end, it didn't come. Yeah, and of course, the mood stabilizers also increase weight. Valproate lithium, mirtazapine increases quite a bit of weight. So that's how it goes. So most of our medicines cause weight gain, and also weight gain is a byproduct of a metabolic dysfunction. Okay, it's not the only problem. So I'm not saying we shouldn't use the medicines. We have to, but we need to understand this a bit more broadly. Now, I suppose you know this as well, that diabetes increases the depression risk by 1.6. So people with diabetes have higher risk of depression. This is the reverse direction, okay? Obesity itself causes poor antidepressant response. IR means insulin resistance. And people who have never been given any medicines in schizophrenia have insulin resistance. So we are thinking, hang on, is schizophrenia kind of a metabolic, is schizophrenia caused by a metabolic dysfunction? Or is it there's a common mechanism that causes schizophrenia and metabolic dysfunction as shown by insulin resistance? We don't know the answer yet. The research is going on. But what we do know is that when people who develop schizophrenia, if they were tested before they got schizophrenia, they are more likely to have insulin resistance. Okay. And bipolar disorder, insulin resistance precedes the onset of bipolar disorder in 50%. Okay. So half the people who develop bipolar disorder already have insulin resistance. And the presence of insulin resistance predicts a worse outcome for bipolar disorder when we come to treat them. They are less responsive to treatment. But then we never identify or test people for insulin resistance, do we? In our management, it is not a part of our treatment. It is not a part of treatment in Sri Lanka. It's not a part of treatment in Australia either. Okay. Nowhere is it a part of treatment yet, but it's of crucial importance. So let's have a look at this thing called insulin resistance. I don't know whether you have heard about it, but since we are not physicians, probably our knowledge is not that much. So let's have a look at it and see what it's all about. So now, insulin resistance doesn't mean that it's only the blood sugar that is a problem. Of course, we know that when insulin resistance means the insulin, the receptors are not working properly, and therefore the insulin has to increase in amount to overcome the block, whatever it is. So there's impaired cellular response to insulin, leading to hyperinsulinemia. And that leads to inflammation, oxidative stress, and dyslipidemia. And the other thing that we didn't know or didn't realize is that insulin is a neuromodulator in the brain. It's not about blood sugar only. Okay, it's a very important neuromodulator in the brain. So if there's insulin resistance, our cognitive functions are impaired as well. Okay, right. So that's a very important thing. So there are receptors for insulin, the hippocampus, prefrontal cortex, and hypothalamus. It also regulates appetite, cognition, and mood in the brain. And low insulin signaling impairs dopamine and serotonin. So that itself can be a cause of, well, depression. So all these things are there. It's a very complex kind of thing. So today we won't go into the nitty-gritty. Uh, that will take a whole lecture in itself, but let's leave it at that. So insulin plays an important role in the brain and our cognitive functions. Remember, it acts on the prefrontal cortex. So that's the part that affects our judgment and everything. Okay. So insulin resistance in depression, there's high insulin resistance, leading therefore to treatment resistance. Schizophrenia and bipolar disorder, baseline insulin resistance is there before the medicines are started. Okay. And cognitive decline, which happens after bipolar disorder, which will come to that, is linked to this insulin resistance. So I don't know whether you knew that up to 50% of individuals with bipolar disorder develop cognitive impairment. Okay, including attention, verbal memory, executive function, even during periods of remission. So that's the most important thing. They are in remission, but they are cognitively impaired up to 50% if you test. But do we ever test people with bipolar disorder who are in remission for cognitive dysfunctions? We don't. Only thing, it's not progressive. It's kind of there. How long it persists and whether it resolves kind of with the treatment, we still don't know it because it's something very new. So what happens in 5 years, we are not clear about that. What we do know is that the risk of dementia is much higher in people with bipolar disorder. Okay. Right. And it seems to all connect to the insulin resistance, which seems to be the central or the bridging factor in causing all this damage. Okay. So that's why the insulin resistance is very important to identify and manage. Okay. So how do you know that somebody has insulin resistance? Without checking, of course. There are clues. So people who are centrally obese have a large waist, and there's something called acanthosis nigricans. I don't know if you've heard of it in your dermatology. I think you get dark patches on your skin, kind of, and skin tags. Skin tags are an indicator you may be having insulin resistance. Okay, and of course, people with polycystic ovarian syndrome, family history, and who are fatigued without any explanation, may be having insulin resistance or something that we didn't think about. Now, these are the clinical clues, but of course, the final test is a laboratory test, obviously. So there are kind of proxy indicators of insulin resistance. For example, fasting glucose over 5.6. The fasting insulin level is elevated. HbA1c is elevated. And a ratio called triglyceride to HDL ratio is over 1.8. Okay. You may know that the cardiovascular risk is better calculated by dividing the triglycerides by the HDL. And if that figure is below 2, closer to 1, you are less likely to get a heart attack or almost zero risk of a cardiovascular event. So you can, if you have done a lipid profile, you can calculate that ratio and see for yourself. However, to calculate the insulin resistance, you need to do the fasting glucose and the fasting insulin. Both are necessary. And there's a calculation, and you get a figure called the HOMA-IR. HOMA-IR, which is more than 2. Since we are not endocrinologists, I'll talk to you a little bit about the HOMA-IR. HOMA stands for homeostatic model assessment. I can never remember these acronyms. So it's HOMA-IR, homeostatic model assessment. IR is insulin resistance. Okay. So this was devised by a chap called Matthews. You can see the reference at the bottom. Many years ago, 1985. So it has not come into practice amazingly. So let's work it through. So for example, if you have a fasting glucose of 5.6 and a fasting insulin level of 12 microunits per ml, the HOMA-IR would be the fasting glucose multiplied by the fasting insulin divided by 22.5. Okay. And then for this example, you get 2.99. You can calculate the maths and see if it's correct. So 2.99. Only thing, make sure the units are correct. Because if they give the insulin levels in another unit, then the calculation won't work. So the two units have to be millimoles per liter and microunits per milliliter for the fasting insulin. Okay. So if the figure is below 1.5, you are fine. Insulin is sensitive. 1.5 to 2 borderline, over 2 insulin resistant. Got it? So HOMA-IR, fasting glucose in millimoles per liter multiplied by fasting insulin in microunits per milliliter divided by 22.5. And that correlates with the gold standard, which is called the euglycemic clamp. Okay, so euglycemic clamp is the gold standard. I'm not going to go into that, but basically what you do in a euglycemic clamp is you give the person a drip of glucose and a drip of insulin. So it gets two drips coming from two sides. And then you calculate the amount of insulin necessary to bring the glucose down to euglycemic, mean normal. So obviously somebody with a high insulin resistance will need more insulin to bring the glucose to normal. Okay, so then that's how you measure in a laboratory accurately. But obviously that's not a very easy thing to do and would be quite uh, difficult. And everybody is well advised to get it done. All of you all, I mean, not the patients, but ourselves, okay? Because otherwise you don't know. You may think you are fine, but you may be shocked to find that you have a good insulin resistance, okay? So it should be a part of our checkup every year, but it's not yet, not even in our patients. So anyway, so that's a very important message, which I think if you remember only this, that would be enough. Okay. Okay, so why does HOMA-IR matters for mental health? Elevated in drug-naive schizophrenia and major depression. Higher scores predict poor antidepressant response and faster cognitive decline. Of course, here it says when to order baseline before you start high-risk antipsychotics. If the BMI is over 27 or family history of diabetes, but that's not correct actually. It should be done in all patients, before you start any treatment, whether you start mood stabilizer, antidepressants, or whatever. Even if you don't do any treatment and give only psychotherapy, still you should do the insulin resistance. Okay. So that bit is not quite correct. So anyway, test after 8-hour fast, consistent units, that's important. Uh, Annually, you should do it. It should be integrated into the metabolic checkpoints, as it is called. And the results are used to guide patient education and motivation. So anyway, we'll come to that. Now, the insulin resistance is called the inflammatory bridge. That's the bridge between everything, okay? Because insulin resistance leads to inflammation. Inflammation meaning not inflammation of the tissues, but it leads to the secretion of inflammatory substances. So some of them are IL-6, TNF, alpha, and CRP. And the inflammation worsens neurotransmission and causes mood dysfunction. It may even cause schizophrenia, okay? And of course, we know that inflammation is a major cause of depression. We know that. And in fact, the anti-inflammatory drugs, there have been studies where they used NSAIDs to treat depression. And there have been some positive studies of that. Okay. Now we can see that how does stress lead to, depression and things. Again, same mechanism. Stress increases cortisol, inflammation worsens neurotransmission, and there you end up with depression. And that we know now that another new thing, adverse childhood. Uh, Neil talks about that in the class. Uh, Adverse childhood events is a major risk factor for bipolar disorder. Okay, so people who get bipolar disorders, a significant majority have adverse childhood traumatic experiences. Okay, why is that? How does that connect? So probably the trauma increases the inflammation and the insulin resistance, and that leads to possible mechanism. We don't know. The research is still ongoing, but that's one possibility. Yeah, so the HPA axis and stress also same pathway. Chronic cortisol increase, hepatic glucose output is increased, insulin resistance, and again, same problem. Sleep deprivation, same problem. Sleep deprivation is a major cause of inflammation, and that leads to metabolic strain, insulin resistance, and the whole outcome is there. And then you have something called the gut-brain axis, and problems there again lead to inflammation, insulin resistance, and same story. So our microbiome, as it's called, significantly important. The book on the side is called A Gut Mood Solution by Professor Gordon Parker, who was the founder of the Black Dog Institute in Australia, Sydney. So he wrote this book, Gut Mood Solution, following a case report, a remarkable case where a lady somebody called Jane, I think you can Google and find, she had a unremitting manic depression, not responding to any medicines at all. So she was married to a scientist, not a doctor, a scientist, who thought, well, maybe if we can kind of settle the gut, we might get some benefit. Now, the reason for the gut problem in this lady was he's had large, enormous rounds of antibiotics because of her adverse childhood experiences. He had a lot of chronic illnesses, and the doctors gave huge amounts of antibiotics, and that probably wiped out the gut flora. So the premise was that if you kind of sort out the gut, her bipolar might improve. So the scientist's husband took a radical step. He did a fecal implant. Now the fecal implant was done using his feces, which hopefully he thought was safe, and given to the wife. Of course, you might see some yucky YouTube videos of where they are blending the feces and kind of, it's there on the internet. You can have a look. She gave a TED talk as well. Anyway, they did this, and she completely recovered from a manic depression without any medicines. And now she remains free of, after many years, she's free completely. Anyway, Gordon Parker, who is quite famous in Australia, heard about this case, and he had a look at it and thought, okay, it is not a fancy one, a fantastic story, but it seems to be true. And then he found 3, 4 other patients who also had a similar recovery. So 5 case histories. And he wrote this book, Gut Mood Solution. Okay. And I think now there are a place in Australia where they give you sterilized fecal implants. Okay. Right. Uh, Anyway, so that's a kind of interesting side to this. So our microbiome plays a crucial role in keeping us healthy mentally. Okay, so the gut and the brain are connected. That's another whole new area, so I won't go into that today. Time is short. Right. Then another way is, of course, what you call shared loci for the body, the index, the schizophrenia and depression. So the genetics and the epigenetics. So what happens, life stresses alter the epigenetics, and that leads to insulin and HP axis dysregulation and leads to stress, inflammation, schizophrenia. So that's another possibility that somehow the genes for schizophrenia and depression kind of lead to combine with stress. The epigenetics of the genes are altered, and therefore the person is at a higher risk. Another possible mechanism, but we still don't know. So we are just looking at theories at the moment. Anyway, we do know this is certain. There's no doubt about this. Mental illness and metabolic dysfunction is a two-way process. One affects the other. And the bridge between the two is one of the main components is insulin resistance. Okay, that's the crucial bridge between mental illness, metabolic dysfunction. So HPA, the insulin resistance combined with inflammation, problems with the HPA axis and the microbiome. Okay, that's the bridge. How exactly this works, it's still in the under study. So you will see a lot of papers coming out, I suppose, very technical papers, so difficult for us clinicians to grasp. Anyway, so let's look at, okay, what do we do with this information? So screening in psychiatry, we are advised, at least by the RANSAP, to do a baseline. So there is what you call RANSAP template, which kind of is an audit of what you should do with patients. So basically, it would say measure the body mass index, waist, BP, glucose, HbA1c, and lipids in all patients who come to your clinic. So physical health monitoring is a core part of psychiatric care. Now, these are from the RANSAP guidelines. Uh, so establish a baseline within the first month of psychiatric treatment. Now, this is done by the GP. Obviously, we assess and tell the GP, okay, do the monitoring. Repeat the monitoring at 3, 6, and 12 months, and after that, annually, increase the frequency if there's a higher risk, of course. For people on clozapine, the monitoring is more intensive. So the results are integrated with the GP and the allied health teams. That's how it operates here. But then Sri Lanka, there's no GP. So you have to take the role of the GP. Okay. So they are going to follow the RANSAP. I don't know, but something to think about. When I practiced, of course, in the private sector, I did the metabolic screening every year for all my patients, irrespective of whether they're on clozapine or not. And my bipolar patients were tested every 6 months. That was my protocol. Okay, nobody told me. But once a year for all the patients and every 6 months for the bipolar patients. Of course, clozapine patients, I kind of said do it monthly, but nobody did it monthly. But anyway, of course, we didn't do everything. We did the fasting blood sugar and the lipid profile. There was no time to do tape measurements and things like that. Uh, but anyway, what they say is to measure the weight, BMI, waist circumference, blood pressure, fasting glucose, HbA1c, lipid profile, and look at the lifestyle factors and remind the patient to exercise, stop smoking, sleep well, eat well. Okay. Right. Easier said than done, of course, because the time is very short with the patient, even here. So we have no time for talking to them about the metabolic issues in practice. However, the point of this lecture is to tell, look, if you don't do that, your treatment is not complete. You can say that's not my job. That's not relevant to my practice. It is because the response to your treatment depends on the metabolic health of the patient. That's the problem. You can't ignore it. Uh, so they have what you call a metabolic checkpoint. In every psychiatric review, the metabolic checkpoint is a component of that review. So basically, it's like in your clinic, every patient gets a question on their metabolic status when they come to the clinic. Okay. Anyway, so you can use the RANSAP audit tool. It's on the web. You can have a look and see what it says. I won't go into that. So it's a 3 months, 6 months, 12 months, every 12 months or 6 months. Okay. Right. Okay. So it's not all about drugs. So lifestyle interventions are important, crucial in reversing insulin resistance. It's not about drugs. It's diet, exercise, sleep, stress management, and drugs. Okay. So if somebody has a problem with their metabolism, you have to do all of these things. One diet recommended is called the Mediterranean diet. So anyway, in that I just put it up, but I don't know how you can modify it in Sri Lanka. But so basically, you can have 20% of fish and seafood and poultry, but no meat, no red meat. Okay, zero or little bit, 5% they allow sweets and stuff. Vegetables 30%, whole grains 35%, olive oil 10%. There are other diets, of course. Some would say you shouldn't have any dairy products at all or any eggs at all because they're highly inflammatory and will cause a problem. So what they would say is a whole grain, non-meat diet. So no cheese, no eggs, no milk other than plant milk, of course. Olive oil, vegetables, and fruits, but not, of course, you can't say fruit and eat all the sweet ones only. Okay. Uh, there are unhealthy fruits as well. Right. Okay. So whole grains, not the ground ones. So pasta, beans, whole grain is, and bread, also not the white bread. Okay. Right. Anyway, something to think about. So each country has to modify according to what they have available. Exercise is crucially important. What they recommend, the WHO, is 150 minutes a week, not all in one day, of course. So what they recommend is 30 minutes into 5. So 30 minutes into 5 is the minimum of aerobic exercise. And that is totally wrong. That's the problem. Of course, having said that, only a small percentage of Americans achieve even that. I know now we have about 20, 30 people listening. I don't know how many of you all come up to this standard, 150 minutes a week. What do you think? Does anybody come up to 150? Well, 30 minutes for 5 days. That's it. Okay, now this is not good enough. We know that that's not good enough. We know that after 40, especially our muscle, we get what you call sarcopenia. We lose muscle, and we have to do weightlifting to maintain the muscles, not to expand, but to maintain what we have. So sarcopenia sometimes starts even earlier. Okay. So after 40, you have to do weights. Just walking 150 minutes is not good enough. Okay. So you have to do a mix of aerobic and weight training. And ideally, it should be not 150 minutes, but at least 1 hour a day, 60 minutes a day. Okay. Uh, so you have to go up to 5 hours a week. And at least half of that should be weight training. Sleep, of course, 7 to 9 hours, no argument about that. And of course, manage your stress with, there are techniques for that, mindfulness, CBT, and a good social interaction. I think that's crucially important for stress management. social engagement. Okay, now these are crucially important, not the medicines, but how much time do we spend with our patients discussing even briefly about diet, exercise, and sleep and managing stress? Okay, so one, two, three, four. Uh, Very little, I think, or hardly at all. Okay, are there pharmacological interventions? Yeah, the easiest one is metformin. And metformin is a wonderful drug. It has hardly any side effects and it improves insulin resistance, reduces weight. Of course, there's another one called pioglitazone. Pioglitazone was a anti-diabetic agent that came in before the GLP-1 agonist came into the picture. Pioglitazone is reasonably safe. Omega-3 and vitamin D may be, but pioglitazone and metformin combined is a fairly powerful and effective intervention. And of course, for the extreme ones, the GLP-1 agonists, what you call semaglutide, is it? Ozempic, people are using it for weight loss, but it can reverse insulin resistance. Of course, they have a lot of side effects, so they have to be careful. But metformin is a no-brainer. In fact, people are saying all psychiatric patients, when you start treatment, you must start metformin also. Okay, before they get anything, you start metformin. With the antipsychotics, with the antidepressant, you start metformin. So basically, all our psychiatric patients on medication should be on metformin. Simple. Whether they have insulin resistance or not. Okay, let's look at this. I thought I'll have a look at this remarkable paper, which is remarkable actually. Uh, Recent one by a group in Canada, Chengap and all, where they, okay, you can read the title, Treating Insulin Resistance with Metformin as a Strategy to Improve Clinical Outcomes in Treatment of Resistant Bipolar Depression, a randomized quadruple mask placebo-controlled trial. Okay, so that's, I don't know what they mean by quadruple mask, but so it's, I suppose, better than a double blind. So anyway, basically what they did, okay, this is what they found. I'll go into details on this. Read the paper yourself. It's available, the full paper. So they want to know whether metformin can be given to people with treatment-resistant bipolar depression and see whether they get better versus people who are not given metformin. And also they wanted to find out, identify the people in this group with insulin resistance and see how that correlates with the metformin. Okay, right. So that was the purpose of the study. So there are 45 participants with bipolar disorder type 1 and 2 and insulin resistance. Okay, they had insulin resistance. Uh, and they were given metformin up to 2000 milligrams a day or placebo for 26 weeks. The main goal was to see whether reversing insulin resistance, and they were called converters, improved depression. Okay. And depression was rated using the MADRS, you know that. After 14 weeks, 11 participants no longer had insulin resistance. Okay. And out of the 11, 10 were on metformin. Only one was on placebo. So that means metformin had a remarkable effect on reversing insulin resistance. And those who reversed and converted had large and sustained improvements in all these scores. And remember that these people, what you call treatment resistant bipolar disorder patients, not normal bipolar patients, treatment resistant. Okay. And the effect size was large. What did we mean by treatment resistant bipolar? That's a new entity, by the way. This wasn't there in the books. This came in the last few years. Schizophrenia we had, but not bipolar disorder. So this committee came to this agreement. Failure to reach remission after two 8-week trials of recommended medications, including combination therapy at therapeutic doses. Okay, so that's the definition of treatment-resistant bipolar disorder. So in these people, what they found was a lot of them had a insulin resistance. And if you treat the insulin resistance with metformin, a significant majority respond to the medications and they recovered. Okay, so if you have any bipolar patients who are not recovering, even if you can't do the insulin resistance, might as well give them metformin and they might respond. Okay. Right. So the conclusion was that improving insulin sensitivity with metformin may relieve depressive symptoms in people with bipolar depression. And it was early evidence that metabolic dysfunction underlies poor treatment response. Okay, we are opening new therapeutic avenues. Okay, we are now coming to the finish. So what we recommend is integrated care, of course. Now that is possible in countries where we have GPs, but it's possible even in Sri Lanka. So you collaborate with the GPs, endocrinologists, and dietitians to give a kind of a integrated care to our patients. Add a metabolic checkpoint to your reviews. Track the weight and the waist and whatever, but actually if you track only the insulin resistance, that will be enough even without any of these. But that's a thought for the day. So basically, this case, what happened was switched to aripiprazole, added metformin, lifestyle changes, mood stabilized. Uh, yeah, the one where olanzapine and gain 20, right? She had a kind of schizoaffective disorder. Okay, so switch to a psychotropic that didn't cause weight gain, added metformin, a few lifestyle changes. Of course, they don't do everything. And the patient was much better. Okay, the mood stabilized, in fact. So what we are looking at, hopefully, for the future is the better kind of psychiatry with new term, metabolomics and a biomarker-guided psychiatry and a personalized integrative care model where all these other people also come into the picture as carers, dietitians, endocrinologists, GP, and us. Okay. Of course, if you can do everything, that's fine, because in the private sector, mostly we operate on our own. So we function at the GP, psychiatrist, physician, everything. That's possible, can do. So just order the insulin. That's it, the fasting insulin. People anyway are paying, so it's well worth the cost, I suppose. I don't know how much it costs, but I don't think it would be very expensive, hopefully. So something to think about and reflect. So mental illness worsens metabolism, metabolic dysfunction worsens mental illness. Insulin resistance is the bridge. And treating metabolic health is a part of psychiatric treatment. It is not left to the physicians to look after. Okay, it's your job. So as Jung said many years ago, the mind and body are two aspects of one reality. Well, we know that now. Okay.